Hello, everyone. My name is Susan Wilburn, and I'm the Sustainability Director of the Global Green and Healthy Hospitals Network, and I want to welcome you to our webinar on mercury-free healthcare, implementing the Minamata Convention. As I said a few minutes ago, as people were arriving, I was going to explain this photograph on the slide. If anyone has guessed the photograph, please send the answer in the chat box to all. And you'll notice that your microphones have been muted. They will remain muted during this present series of presentations. If you have any questions during any time during the course of the webinar, please write the question in the chat box. Thank you again for joining us. Good morning to those of you in the Americas. Good afternoon in Europe and Africa. And good evening, and thanks for staying up late with us, to our speaker, Fayfarer, and those of you in the Asian and Pacific regions of the world. This photograph on the cover of the slide is a beautiful fountain that was first displayed in the 1937 World's Fair in Spain. This is a photograph by the painter. This photograph is a sculpture by the painter Alexander Calder, and it is Mercury in motion. And it is a tribute and a monument to the Almaden mine in Spain, which it used to be the largest producing and mine in the world of mercury, of this very toxic substance, about which we'll be talking today. On August 16, 2017, the Minamata Convention on Mercury came into full force with 128 nations signing the convention and 74 countries ratifying. The convention required 50 ratifications for it to come into full force, which it did again just 2 weeks ago, an historic event. The protection of human health is at the core of the Minamata Convention, whose objective in Article 1 is, quote, to protect the human health and environment from anthropogenic emissions and releases of mercury and mercury compounds. This was the first global convention to include an article dedicated to the health aspects of an environmental contaminant. And you can see on the slide the language related to Article 16. And before we get to speaking more about implementing the Minamata Convention with our two distinguished speakers, I'd like to tell you just a little bit about the network, our Global Green and Healthy Hospitals Network, an international network of hospitals, healthcare facilities, health systems, and health organizations, all dedicated to reducing our environmental footprint of healthcare activities while promoting public health and the environment. We have a 10-goal framework as its foundation. This framework, you can see there are 10 interconnected goals related to the Sustainable Development Goals for the health sector to address and promote greater sustainability. The area of mercury-free healthcare is that listed in the chemicals goal that you can see, the second goal on the left. Now the slide shows a map of the world where our members are participating in this network. As of August of 2017, we have 869 members from 49 countries, representing the interests of over 28,000 hospitals and health centers. And the countries that are represented are colored on the map. You can see in the Americas region, quite extensive. In Africa, we're growing in size. In Asia, quite extensive. And Western Europe, more than Eastern Europe. What you also see on the map is a star where there are Healthcare Without Harm regional offices in Buenos Aires, in Washington, D.C., in Brussels, in Belgium, and Manila in the Philippines, and red dots where we have strategic partners that we work with to implement these goals. There are many benefits and programs within the Global Green and Healthy Hospitals Network that you can see on screen. I'll just cruise through examples of a few of them. Guidance documents in all of the 10 goal areas, webinars such as this webinar today, case studies that are examples of successful project implementation so that hospitals can learn from each other how to make progress on the goals that they've chosen among the 10-goal framework. There are many benefits of membership. We have an award structure. There are videos and testimonials. You'll see the example of the video from our colleague Christina Gear in Region Skåne in Sweden. And we have our social media platform, GGHH Connect, which is an online innovative platform where we have discussion groups in each of the 10-goal areas. And it also includes our Hippocrates data center, the platform that's designed to measure actions towards reducing healthcare's environmental footprint. And with that, I want to introduce our speakers for the webinar today. The first and lead speaker is Professor Peter Orris, MD, MPH, who's the Chief of Service of Occupational Health Service Institute within the University of Illinois Hospital and Health Sciences System in the United States. This strategic work of Dr. Orris has been critical to the worldwide environmental health movement, including and especially the Minamata Convention. Dr. Orris was one of Healthcare Without Harm founders in 1996, now over 20 years ago, and has advised communities all over the world on the dangers of incineration and other toxic chemical exposures. Dr. Orris attended every negotiating session of the Minamata Treaty on Mercury and was a critical clinical voice in the negotiations to inform governments about the dangers of mercury, the availability of safer measuring devices, and the momentum of the health sector in eliminating mercury from their facilities. As a result of his advocacy with Healthcare Without Harm staff and allies around the world, the Minamata Convention contains the provision, Article 16, for the global phase-out of mercury-based measuring devices by the year 2020. Welcome, Peter Orris. The following speaker will be Faye Ferrer. Faye is the coordinator for Global Green and Healthy Hospitals Network in the Southeast Asian region. She led the first Southeast Asian Mercury-free healthcare conference that was held in the Philippines in 2006, and the WHO and Healthcare Without Harm Mercury-free healthcare initiative in the region. This work provided an instrumental input into the Minamata Convention on Mercury negotiations because it showed that substituting mercury-containing measuring devices in healthcare was achievable and could be done. Faye led the Safer Chemicals campaign in Asia and developed collaborative partnerships between Healthcare Without Harm and other non-governmental organizations such as the Citizens Alliance for Consumer Protection, the Legal Rights and Natural Resources Center, Kamasama Kalikasan, Greenpeace Southeast Asia, and the Clean Energy Tour of Southeast Asia. Welcome, Faye. I've also put my bio up on the screen and photographs, but I won't tell you any more about myself than I'm the Sustainability Director for the Global Green and Healthy Hospitals Network. With that, I'd like to turn the ball over to Dr. Orris for the presentation about the Minamata Convention. Welcome, Peter.
Thank you, Susan. Appreciate it, and the, if you will, overly fulsome introduction, but I appreciate it nonetheless. I should also add that Dr. Lillian Cora, an early supporter and of Healthcare Without Harm, a neonatologist from Argentina, was as well present at the negotiating sessions and was greatly responsible for the health language in the final treaty. Let me just begin with a bit of background on mercury and why we became interested in this as environmental epidemiologists and environmental toxicologists some time ago. Mercury appears in three different forms in common usage. The elemental form, which we're all familiar with, is the liquid mercury, behaving quite differently from most other metals, and something that many of us were taught to play with as children. I no longer have a slide of this as modeling bad behavior, I have been told is not the best way to begin this approach to mercury. Additionally, inorganic salts of mercury, mercuric chloride, were used as an antiseptic for many years as well, but now has been phased out medically, globally, in favor of other less toxic and more effective products. Finally, there is the organic form, and that is the one that we are particularly interested in, and specifically methyl mercury, as the organic form that is most commonly molded by nature from releases of metallic mercury, either from anthropogenic sources such as our use of mercury in healthcare, or when one digs for fossil fuels underground, one naturally comes up with mercury as well, and then in burning fossil fuels, one liberates that mercury into the atmosphere, or through gold mining and other things where mercury may be used in its metallic form. All of these metallic forms of mercury, or rather all of these uses of the metallic form of mercury, is then spread across the surface of the planet, as opposed to where most mercury is held, and that is beneath the surface and safely away from human beings, except for developments such as volcanoes and others that may naturally spread some of this around. It is the anthropogenic mercury, in addition to that natural mercury, that we are primarily concerned about. And we're concerned about it because, as you can see on this slide, what occurs with this mercury is it winds up in aquatic environments, and it is then methylated by microorganisms in those aquatic environments to produce methyl mercury. This methyl mercury is then concentrated in the food chain, specifically from those microorganisms up through fish, and finally eaten by people at some 6 million times what it was in the microorganisms themselves in the aquatic environment. This is unfortunate, as we have now learned that extraordinarily low dosage of this methyl mercury has an impact on the developmental brain as the fetus developing during pregnancy, and this impact on fetal brains is carried over into early childhood, and then as far along as we can measure, and scientifically this has been measured through 11 years of age. It is a hidden toxicity often because it affects higher nervous system functioning in the central nervous system, often that of attention, visual, spatial, language, and memory impacts, more so than peripheral neuropathic impacts. In fact, we know now that for every microgram per gram of mercury in the mother's hair, we know that there is close to a 1-point drop in intelligence on all intelligence measures. It's 0.7 points as measured by the Harvard Center of Risk Analysis some time ago. The meaning of this decrease, though invisible clinically, because often it is some 5 points total for a child, and therefore not identifiable in the interaction with the pediatrician. But the meaning for this for a society as a whole on a population toxicity is some 1.3 billion within the U.S., coming purely from our coal-fired power plants. This was calculated a number of years ago, before these plants began to be closed down and reduced in size, though they still are a significant portion of the energy grid in the U.S. Unfortunately, we are unable to tell a patient clinically either who is thinking of becoming pregnant how to protect herself specifically and her baby, because as you can see, there is quite substantial differences between different fish varieties, and within those varieties, depending on where they have been caught in the world, you may see great variation of the amount of mercury and methyl mercury in these fish. So it is very hard for an individual who is thinking of becoming pregnant or is pregnant how to increase the amount of fish they're eating, which is very good because of the omega-3 fatty acids for brain development, but how to decrease the mercury within the fish that they're consuming. This makes it imperative for us to talk about getting mercury out of the fish and not fish out of the mothers, because the fish or rather the ability of that individual woman is quite restrained in terms of the amount of mercury that she can actively control herself. We then go to the sources of mercury, and I've talked about the most important ones globally: coal-fired power plants and artisanal mining of gold and the amalgamation that is used to get pure gold out of that process. But I don't want to leave out the healthcare system. In the U.S., when we still had around 2,000 healthcare incinerators, we were producing about 10% of the total U.S. pollution from mercury. Now, since there's only 2 or 3 centralized and well-controlled incinerators remaining in the country, this contribution has been greatly reduced within the U.S. The sources of mercury in healthcare we would highlight are the thermometers and sphygmomanometers, in addition to the dental amalgams. There are other and potentially larger individual device sources, but those devices are not used as much and therefore are not major sources with healthcare. The question presented to us here was, as usual, a scientific question, and that is, were there alternatives to mercury thermometers and sphygmomanometers that were equally good clinically, but did not involve the exposures to mercury? And this is a paper that we did early on with respect to those alternatives. We additionally worked with WHO on these matters because of WHO's commitment to reducing mercury from healthcare, specifically on those devices. As part of that process, the World Medical Association turned and looked at the question of our behavior as physicians in using these mercury devices, and agreed that we could in fact substitute them for non-mercury components. And that this would be important in reducing the global mercury contamination that we were concerned about. As I said early on, WHO identified this as a problem and advocated for the elimination, reduction initially, and then elimination of mercury from healthcare everywhere possible. And this was a paper that was developed in August 2005. Early on, we discovered that there were a variety of non-mercury thermometers available on the market, and I know you'll hear more from Ms. Ferrer about this later on. There are pros and cons for each of these, and the most important component of substitution of anything in healthcare is to understand how to utilize and safely utilize the new devices. The important thing for us in substituting, and really the startling thing that we learned as clinicians, having practiced for 35 years general internal medicine on the teaching wards at Cook County Hospital in Chicago, I never considered the aspects of how I should be using mercury thermometers and mercury sphygmomanometers in clinical practice, and what was the best way of doing it both clinically and for the reduction of exposures. The mercury digital thermometers, as one replacement, have very accurate and useful international standards developed by ISO and others for the replacement. The key element on replacement of mercury thermometers is the understanding that breakage is a major problem globally, and one digital electronic thermometer will work for the duration of at least 4 to 5 mercury thermometers. So the equivalent and the economics there is very important, since those digital thermometers in general are somewhat more expensive, although the individual market impacts on that and their use impacts on that, the amount of use. When we turned our attention next to what we thought was a bigger problem, and that is mercury sphygmomanometers, we discovered that WHO had well calculated that this was the largest mercury reservoir in healthcare settings. And then the question became, what about substitution? And it turned out that there were multiple alternatives that were able to be used if understood in how to use them accurately, etc. It also developed that we had not paid enough attention to what we had considered the gold standard in measurement of blood pressure, and that was a mercury sphygmomanometer. And as I indicated, during my 35 years at County Hospital, I hadn't considered how to use this, and always considered it as a gold standard. Notwithstanding the fact that almost no other technology in healthcare has been used as a gold standard for 135 years, actually longer than that now, we still look to that as the gold standard. And it turned out that we were misapplying the term, even if you thought that the manometer, and it turns out that the mercury manometer, the measuring device labeled number 1 in this picture, is a gold standard for measuring, and today with the alternative electronic measures that are available, this would no longer be true. But even if we consider that true, the actual taking of blood pressure includes all of these additional factors which all impact on the accuracy of the pressure itself. And most importantly, this is the patient, the healthcare provider, and then secondarily, it is the mechanism by which we assess the blood pressure, and that has to do with the size of the blood pressure cuff, the actual stethoscope one is using, how one registers the sounds on the stethoscope, and what one models, and finally the tubing itself. But again, these are less important than the patient, white coat blood hypertension, it's called, where patient's blood pressure goes up measurably when it's being taken by a healthcare provider. And then finally, interestingly, our human interest in 0 and 5, in which we frequently round down and up the measurements we take in blood pressure to 0 and 5. When one looks at the alternatives available now, we find them to be often more accurate, absolutely equally able to be utilized in a clinical setting for all potential clinical purposes, but as well with each of their individual criteria and necessity for calibration and schedule for calibration. The mercury versus the electronic stethoscopes are often 10 times more accurate than the mercury ones, in other words, the electronic ones themselves, if used properly with the proper controls. They too have now freely available on the web, good third-party evaluations as to which is an appropriate one to use where, and the accuracy that these need to be maintained. There are lists of validated non-mercury sphygmomanometers available, and as I said, often more accurate than the original mercury ones. One comes from the British Hypertension Society. Mercury replacement, therefore, in healthcare is both possible and advisable. We worked with the World Health Organization in developing an advisory to clinicians as well as ministries of health of how to go about replacement of mercury in healthcare and how to do it in a way that not only does not compromise clinical care, but in fact improves the accuracy of these devices. A lot of this is now available on the Healthcare Without Harm affiliated organization to Global Green and Healthy Hospitals Network websites in English and Spanish and numbers of other languages. This led us to involvement in the international mercury negotiations, for which we became very interested because we felt that since we were only contributing, it would seem, up to 10% of the mercury pollution in the world, our approach to modifying our behavior in healthcare would be instructive and helpful for society as a whole. And this treaty, which was negotiated and has just come into effect, was an important methodology to communicate our concerns for the other sources and involvement. Sorry, I seem to have gone over a slide. We were primarily involved in that treaty, of course, in these products that I have so far been talking about. Fortunately, we had arrived at consensus within the health sector, and that was transmitted to the negotiators during this convention, and without wiggle words at all, it was agreed by everybody involved in the negotiations that the kind of devices that I have been describing to you would be phased out by 2020. There is the possibility of a country asking for a 5-year extension on that, but there was not a question that total phase-out was possible and advisable there. We additionally were happy to collaborate with Dr. Cora and others on the development of this Article 16 on the health aspects of phasing out mercury in all of its components, specifically the major aspects of fossil fuel generation and coal-fired power plants. We were happy to do so, and we think that this is a model article for environmental treaties and the first one of its sort in any of the prior environmental treaties over the years. We then turned attention to the more difficult aspect, and that is the involvement of mercury in dental amalgams, fortunately a smaller source than the prior ones that we have been discussing, but just as, excuse me, problematical as we move ahead on the question of moving away from mercury component as a whole. And despite a major debate within dental practitioners concerning the use and importance of dental amalgam, the market itself for this and the practice of dental practitioners globally is moving steadily away from mercury and to the use of alternatives around the world. This was codified within the treaty with agreement of all the components of the dental practitioners on both sides of this issue, with a desire to phase down the use of mercury and, where possible, eliminate its use in dental amalgam. And I would like to thank you all for listening to me today. The slides that I have utilized come from a variety of sources, and I appreciate my colleagues and others for allowing me to edit them as I have. Thank you again, and I turn the floor back to Susan Wilburn. Thank you.
Thank you so much, Dr. Orris, for a comprehensive and efficient presentation about the sources, impacts, and outcomes of the Minamata Convention. A reminder to all that if you have questions for Dr. Orris or for our next speaker, Faith Farrer, please put them in the chat box, and we'll have time at the end of the next presentation to respond to those questions. With that, I'd like to turn the ball over to Faye. Sonia, can you do that for us? And welcome Faith Farrer, the coordinator of the Global Green and Healthy Hospitals Network in Southeast Asia.
I think Peter or Ale can move the ball.
Okay.
There you go.
Okay, great. Thank you, Susan, and thank you for the very good, very comprehensive introduction of Dr. Peter Orris. I am speaking right now on behalf of the work that we've done in the Southeast Asian region on how to phase out mercury-free healthcare. So just to give you an idea about the mercury-free alternatives, and as Dr. Orris has already mentioned, that alternatives can be as accurate as the mercury devices. Mercury-free alternatives must also meet existing standards, and alternatives of unknown quality should be validated before use. And like mercury sphygmomanometers, aneroid blood pressure devices should be periodically maintained and calibrated. So I think most of you would know that aside from mercury thermometers and sphygmomanometers, there are other mercury-containing devices within the hospitals. But since we're only talking about the phase-out of thermometers and sphygmomanometers by 2020, let me just elaborate more on thermometers and sphygmomanometers. For some of those who are not yet familiar with alternatives for mercury-containing thermometers and sphygmomanometers, Dr. Orris has already mentioned in his presentation, there are a substantial number of alternatives available for both thermometers and sphygmomanometers. And let me just give you some examples. First, it's for non-mercury thermometers. In Dr. Orris' slide, you've seen the thermistor-based digital thermometers. There are also phase change or dot matrix types of thermometers. There's also tympanic infrared thermometers, and there are temporal artery infrared thermometers. These are just some, and there are many more that are available in many other countries like gallon stand in-glass thermometers, alcohol dye, thermochromic, and thermocouple and platinum resistance type of non-mercury thermometers. For non-mercury sphygmomanometers, again, as Dr. Orris has mentioned, we're very surprised that there are also different types of alternatives available. There can be mechanical dial aneroid sphygmomanometers. There are the digital type display and the electronic oscillometric sphygmomanometers. The Doppler, the Foltocell, and the strain gauge-based blood pressure devices are available as well. What we wanted to always address to healthcare facilities and hospitals that would like to do the phase-out is that there are key specifications for both non-mercury digital thermometers and non-mercury digital sphygmomanometers that are available that you can reference to when you are going to make the phase out. So in order to do the phase out, what we have done within the course of the campaign that we've done is that we have worked with the World Health Organization in working on key steps in developing and implementing national health system-wide strategies and also a healthcare-wide strategy on how to phase out mercury in your healthcare. For a national strategy, there are 4 recommended steps wherein your hospital or your countries can work on. First is to develop a stakeholder engagement strategy. 2 is to do a situation assessment and inventory of existing mercurial devices. 3 is to strategize, development, and implement those policies, and then monitoring and reporting. For a hospital or healthcare facility-wide, we are recommending 5 steps, and all of this guidance, all of these documents are available in the Global Green and Healthy Hospitals website, and also at the Healthcare Without Harm website. So for a hospital-wide phase-out setup, we have 5 steps that hospitals can really work on. One is to create a mercury elimination task force, which would do the work so that the whole hospital won't have to be affected. The task force is your point person or group that would work on the elimination, and then have the hospital management sign a pledge or a commitment letter to phase out mercury. And then one of the most important things is to conduct a mercury inventory and then develop the mercury substitution program. That would include replacement of the devices, creating a purchasing policy, and establishing a mercury waste management, and also to train and educate not only the workers in the hospitals, but even the patients that are coming in the hospitals. And then 5, make a post-implementation evaluation. So as Dr. Orris has mentioned, we, in collaboration with the WHO, Healthcare Without Harm has a publication that hospitals can reference in terms of replacement of mercury thermometers and sphygmomanometers. We also have created a survey form for hospitals in terms of auditing the existing number of thermometers and sphygmomanometers that they want, that they would like to know how many are there still in their facilities. So just to give you an example, it's very small, but in a survey that was done through the UNDP-GEF or UN Environment, you can see here several countries like Argentina, India, Philippines, and Vietnam. And the survey that they did, the one on the right is the number of mercury per bed per year that was surveyed. And this is the one surveyed for the mercury sphygmomanometers. We also have created guides to alternatives. This is our response when the Philippine Department of Health has announced that they would be phasing out sphygmomanometers and thermometers from their healthcare facilities. So Healthcare Without Harm has worked on the market, provided this publication to tell hospitals that there are indeed alternatives already available and is ready to be purchased. There's also some forms that can also be used just to work on the cost of alternatives compared to the mercurial devices. And also one of the questions that have been always raised to us is how to store the phased-out mercury thermometers and sphygmomanometers. Later on, in one of the case studies that I would be presenting, there is a hospital in the Philippines that have used this guidance document to store their phased-out mercury. And just to give you an example of how a national policy was created, in 2007, the Philippine Department of Health has announced that in 2 years' time, they would work on the phase-out of mercury thermometers and sphygmomanometers. So that is the total phase-out was done in 2010. And as something that we worked on in the campaign, we've created the guide for eliminating mercury for healthcare establishments, and we've gone through all of the regions in the Philippines to campaign together with the Department of Health for the phase out of mercury in healthcare. So this is one case sample in the Philippines. This is just one of the example on how when they conducted the mercury audit and inventory, this is how mercury are stored in different hospitals in the Philippines. And one example is the San Lazaro Hospital in the Philippines, wherein after their inventory, they've gathered 74 pieces of sphygmomanometers, both intact and broken. They've also gathered 36 pieces of thermometers, both intact and broken. and the personal protective equipment used in the cleanup of mercury spills. So the next slides would be the step-by-step way that they stored their spaced out mercury thermometers and sphygmomanometers. As you can see with this first slide, they prepared the desktop sphygmomanometer for storage. If you want I think the photos are small. I can give you a bigger one if you need to. So all of the photos and the system that they've done is prepared via the UNDP document. So that's the preparation for storage. That's for the first slide is for the sphygmomanometer. The second slide is for the thermometers. This one is for the primary container to prevent spillage. So as you can see here, this is the desktop type sphygmomanometer. And then you have the primary container, again, to prevent spillage. And then labeling of primary container is very important so that when you place your phased out thermometer, sphygmomanometer, it will be clearly read by people who will see it. And then, as you can see, the primary container on the yellow plastic bag would be contained on a second container to prevent further spillage in case of breakages. And then the secondary container that was used will be sealed to prevent further spillage. So sealing is very important in order for it not to be reopened again. And then as to end the whole process is to label it clearly on how many of the devices are contained in that secondary container. Another case sample is from Argentina. This is from the Hospital Universitas Austral. What they did is from November 2008, they have already pledged that no more mercury devices were to be purchased by the hospital. The toxicology, medical management, and pharmacy were tasked to evaluate the quality and the price and purchases that were made by the hospitals. Electronic measuring devices were placed in the OR and the therapy rooms, and staff were trained via personal emails, newsletters, hospital magazines, and signages. By March 2009, mercury-containing thermometers were replaced, and the results of the phase-out were measured by surveys in the affected sector. And it turned out a positive attitude towards the change were detected. By 2010, tensiometers were also replaced, and graphic campaign was launched in the community and were offered to bring their thermometers to the hospital. By 2011, personal thermometers were given to each patient as part of their admission kits, and they are able to bring it home after their discharge. Tympanic thermometers were placed in high replacement areas such as ORs and day hospitals. So like what the Philippines has done, signages and posters are very important, and this is what the Hospital Universitas Austral has done. So those two case studies are just some of the studies that we've done in terms of phasing out mercury thermometers and sphygmomanometers in hospitals. And that's it. Thank you so much.
Thank you very much, Faye, for a very useful and practical presentation, and including some of the challenges that our hospitals will be facing as they move to substitute the mercury-containing thermometers and sphygmomanometers, as will be required under Minamata by 2020. And some of the work that Faye was talking about was supported by the Global Environmental Facility in a project that Healthcare Without Harm participated with the UNDP and WHO in 7 countries over the course of a number of years. And there's a new project also funded by the GEF that is ongoing in 4 African countries. And those countries, some of whom are on the call today, I'd like to welcome you to this webinar, will be receiving their mercury-free substitutes starting on the 21st of September. So lots of non-mercury thermometers and sphygmomanometers will be being distributed throughout the African continent later this month. With that, I invite you again to put your questions in the chat box. We have had a number of questions come in. I'm going to start with a question about waste treatment for you, Dr. Orris. The question is, I would like to know what we should verify if we want to know that the company treating our medical waste has the necessary controls in order to avoid mercury emissions during the treatment. Peter, you need to unmute yourself.
Yes. Can you hear me now?
Yes.
All right, excellent. Well, the first thing that should be thought of with respect to waste treatment in medical care is that incineration is in fact technically unnecessary in medical care. Now, in the state of the art today on a global level, incineration is required in many countries, at least for the potentially infectious components of waste coming from healthcare institutions. With those technical, or rather with those legal requirements, the accurate separation of what is really just hotel or normal municipal waste from waste coming that may be potentially infectious is very important, and is important for the bottom line of those healthcare institutions, because incineration of infectious waste is far more expensive than the landfilling or other disposal methods for the regular hotel waste. Having said that, if incineration is being used, then rather expensive control devices such as bag houses and other things of the sort are necessary to control the mercury coming out of the stacks, especially if thermometers and sphygmomanometers and other devices may be put into that incineration flow. If it is not being used, then other methods are available to segregate the mercury out. Having said that, an engineer with experience in this area is important. My medical degree does not help me with the specifics of how one needs to take the mercury out of the stacks in this situation.
Thank you very much. And as people, we have three more questions that are related to waste. The first one is for you, Faye, and that is there. So the question, Faye, is the sealed mercury stored in the hospital or other agency? And I'll ask the second question, which is, although the first committee of the parties will occur in September, do you have ideas about how governments will manage mercury waste during the phase-out? And we know that this area, as we're switching from mercury to non-mercury, what you're going to do with the toxic waste is going to be a major challenge for countries. So, Faye, perhaps you want to start, and Peter, you can add.
That's one of the most challenging questions that we are always faced with. What we used to tell, and still insist on telling the hospitals that are going into phasing out, is that the safest still is within their hospitals, because they know what the waste is. They know the procedures on how to store it, and it will not really require a big area for it to be stored. And we hope that by COP1 in September, that countries would be able to really look for a more permanent or a more centralized way to store it. But as an interim, we are really encouraging hospitals to not be discouraged, not to phase out, just because they do not have the means, or they are thinking that they do not have the area or the room or the space to store it.
Anything to add, Peter?
No,
in
I'm
terms of-
hopeful that as well, that COP1 will deal with the question of the ultimate destination for these mercury wastes, because we have collected them in any number of situations, batteries and others, and are often storing them in place. Better than releasing them to the environment, but not as good as coming to a centralized ultimate storage.
And I would add that there is a publication by UN Environment that was done with the support of the Japanese government. As you know, Minamata is in Japan. That is all about mercury storage. It's about a 300-page document that governments and others can use to develop their storage methodology. And a last question on waste, and then there's a number of questions about dental amalgams. The last question on waste for you, Faye, is when the reduction of mercury devices is implemented, what protocols are being enforced for a mercury spill kit or materials needed to contain such a spill?
Well, it will depend on the hospitals. If they have already phased out all of their the mercurial devices, the important one is to train hospital personnel on in cases of spills. The UNDP guide on this, or UN Environment guide on in terms of spills, is very accurate in terms of how to contain a spill where in terms of the size, if it's just one thermometer or a sphygmomanometer, which is a bigger problem. But all of those are available and should be part of when you start with the storage of your devices.
Thanks, Faye. And there is within the materials on the Healthcare Without Harm website directions on how to create a mercury spill kit and what materials to contain. There's a lot of questions about production and waste. As the convention is now in force already, does it mean that manufacturers have already stopped production of mercury devices, or would they wait for the COP1 deliberations? Peter, do you want to take that?
I have not. Well, let's start with thermometers. There is a very limited production globally of thermometers, and I understand that there will be some plans to switch from production of mercury to non-mercury thermometers in some of the larger locations in China. But I am not an expert on the supply market, and it is my understanding that no overall shutdown of mercury thermometers production has occurred, and they are still in use in many places in the world. With respect to sphygmomanometers, the answer would be exactly the same. I think we'll learn more at COP1 as the major producing countries report on their situation.
And as the convention says, that the production and export and import and purchase of mercury-containing measuring devices must end by 2020. As Peter mentioned in his presentation, countries can ask for an extension, but no countries have done so. And the expectation that WHO has shared with us is that there will be no devices available after the year 2020. And so the sooner that you move to get your replacements, the easier you'll be able to find the non-mercury products as the markets rush to meet the new demand. Now there's a couple of questions about mercury amalgam. The first question is, what are the substitutes for mercury-free, and how do you find out more about mercury-free substitutes? The second question around dental amalgam is, I'm interested in having ideas about mercury-free dentistry initiatives and what countries have improved mercury-free dental school curriculum and mercury-containing waste management in dental hospitals and clinics.
This gets into an area that is quite complex, and excuse me, just one moment. And quite complex, and as well is an area that, in general, in our approach to questions of environmental health and clinical care, we defer to the clinicians frequently on what is necessary and in what situation clinically. And with respect to the dentist, there is a very lively and international debate on exactly where one needs mercury amalgams and if they are necessary at all. There is a good deal on the website. More can be learned by communicating with us after this webinar through GGHH or directly to me at the University of Illinois, and we can direct you some of these websites. Safe to say that Scandinavia and Europe and the US have eliminated nearly all of the mercury in use in dental amalgam. Scandinavia specifically has, in fact, in a number of countries, banned the use of mercury amalgams. It's a virtual ban with the escape valve that if a clinician wants to use it, they can use it in different settings. But there have been no, to my knowledge, requests in those countries for the continued use of mercury. So there's a great deal of information there. In the dental professional organizations, there's a lively debate, and we would be glad to send you that information. I should add, by the way, that the market itself is, I showed one slide, is rapidly moving from China to the Philippines to Africa, where patients are demanding the use of non-mercury amalgams.
And Peter, do you want to comment about traps in dental clinics?
Yes, these are very important, especially in settings in which there is no environmental control at the moment. On the other hand, these are partial solutions. There are some excellent papers, specifically around the U.S., in which dental offices have attempted to remove all of the mercury waste from their own offices and have done an excellent job using the state-of-the-art technologies to do so. But an excellent job is not a complete removal of all of the mercury waste, so they still are putting mercury into the water supply and the wastewater supply in the U.S., even if they are using these state-of-the-art waste control methodologies. So while it's a good interim approach in many areas, and there may be some international support for that, it is not the ultimate solution with respect to the environmental exposure to methyl mercury.
And there's some case study examples from work that UN Environment has done in Kenya and Tanzania on the installation of traps for dental amalgam in the effort to phase down the use of mercury in the African setting. So some interesting case examples. And we have time for one more question, and I'll start with Faye on this question and see if, Peter, you want to add or summarize anything at the end. In phasing out mercury-containing medical devices, hospitals can choose one of two strategies. One is to replace mercury-containing devices with non-mercury devices gradually, that is, as the former break or otherwise become unusable. The other approach is to retrieve and retire mercury-containing devices wholesale and safely store or safely dispose of them. What are the pros and cons of each approach? Under what circumstances should a hospital choose one strategy or the other? In your experience, Faye, what works best?
Oh, that's a good question. Well, it really depends on, one, if there is an availability of the alternatives already in the country or within certain area. Well, what works best for most of the hospitals that we work with is they replace it wholesale. That means they've found the alternatives, they phase out everything altogether, But in some of the hospitals that we are currently engaging with, what they are doing now is that if it's rendered useless, that's the only time that they will replace it. So if I will recommend on the basis of the work that I've done and how urgent the issue is in terms of replacement, first is to find alternatives and then replace it wholesale. That's my recommendation.
And do you do it unit by unit or by the hospital all at once?
Well, again, it will depend on the hospital, but again, if the audit will reflect that it's not that big of an amount in terms of the number of mercurial devices, especially on sphygmomanometers, they can do it hospital-wide. And then again, it will depend on the size of the hospital. But it will not also be a problem if they would do it by department as well.
Thank you very much, Faith-Farer. Peter, do you want to have the last word? Anything to add or summarize?
Yeah, only to say thank you all very much for the interest in this topic. Obviously, a 1-hour webinar only touches the areas and doesn't get into the details that are necessary to put this practice in place. But the materials are there, as both Faye and Susan pointed out. They are applicable, and we're all available to answer any questions that might be asked. I would be interested in talking to any of the clinicians that have concerns about either the accuracy of these replacement products or the importance of the mercury toxicity for neurodevelopment. Thank you very much.
Thank you very much, Professor Peter Orris and Faye-Farer. You'll see on the screen that I've put up the slide about how to become a member of the Global Green and Healthy Hospitals Network. Join by sending your letter of intent online. We will take any of the questions we were not able to address during this hour and put them into the answers on the Mercury Chemicals community on GGHH Connect for members. And the webinar itself, the tape will be available on our YouTube site in the coming weeks. Just again to thank you for joining us today. You will receive in your server, your web server, an evaluation. It is important to us. Your responses and recommendations for future webinars. Our next webinar date to be determined will be in October, and it's about the launch of the Hippocrates Health Challenges on Waste and Energy. Stay tuned to the date for that webinar. Thank you very much again. Have a good day. See you next time. Bye, everyone.